With that, without further ado, I would like to welcome Dr. Jack Kerrigan, who is the medical co-director of the Hypothalamic Hamartoma program at the Barrow Neurological Institute, and also our founding chairman of our medical advisory board, among many other commitments and services that he provides. And we are very grateful and blessed to have him here today. Thank you.
Well, good morning, everyone. I hope everybody gets a little time to spend some time out in Washington, D.C. a little bit. I went to the Capitol yesterday, and it was a nice experience because there wasn't a large crowd. So actually, it seems like it's a good time to go visit some things while you're here. Eileen asked that that all the speakers leave some time for questions and answers at the end. So I've got about 30 some odd slides here. So we should have some time for questions and answers. So please think of them as we're going through, and then we'll be able to do that. Here's a summary slide for what I'm going to be doing this morning. Excuse me. I'm going to do a very brief overview of HH. It's a very complicated topic on often very complicated patients. But I know that there's a lot of diversity in the audience today in terms of families who have had a lot of experience with it. Eileen mentioned families that have been dealing with it for decades, and also families I've already met this morning who are relatively new to it with a relatively new diagnosis or on the steep part of the learning curve. I want to speak about what we have learned over the last few years, which has been really quite a lot, and it's in a short time, it's not possible to really kind of go through every single research discovery, but some of them are more important than others, and some of them I think I really want you guys to know about. And then, where the rubber hits the road, of course, for families and for patients is what's new with treatment. And so I want to really address the treatment landscape as well, which has been a very rapidly moving experience for all of us, quite frankly. So hypothalamic hamartoma comes in two types. This is a coronal MRI scan here, so the top of the head, the right ear is over here, the left ear is over here. These are the lateral ventricles of the brain. This is the third ventricle, which is, of course, a fluid-filled space. And the hypothalamus is the structure on each side of that third ventricle. And here we have a small structure here, a small lesion there that doesn't belong there. And of course, that's the HH lesion. And so the traditional way of looking at HH lesions was the intrahypothalamic type, that is to say, lesions that are up within the third ventricle itself. And those are the ones that are classically associated with neurological problems. So gelastic seizures at a later time point associated with other seizure types, and also are associated with the comorbidity that is really such a challenge for patients and families, which includes the cognitive issues and the psychiatric issues that I'm going to touch on briefly. About 40% of patients who have HH with epilepsy also have precocious puberty, which is the other type. So the parahypothalamic type are the lesions that hang off the bottom, are not within the third ventricle itself, but basically often have a stalk off the bottom of the hypothalamus. And those are the lesions that are associated with precocious puberty and usually don't have the epilepsy, the cognitive issues, and the psychiatric issues. So with today's audience, I'm going to really focus in on the neurological part, and I'm not going to say too much more about the precocious puberty part of the story. However, what becomes really clear, though, when you have the opportunity to work with a lot of patients is that this is really not a dichotomy with two different poles wholly distinct from each other, but rather it is a completely smooth continuum from one patient to another. So that if we kind of just go clockwise here, you can see that this lesion is completely within the third ventricle. We begin to span across, we get some very complicated lesions, and then here's the study that I showed you initially. However, all four of these patients have epilepsy, and for reasons that I'll tell you a little bit later, the important anatomy isn't so much this view, whether it's in the ventricle or below, but rather there's some other things that we've learned about the anatomy that turn out to be even more important. This slide also, I've just mentioned the diversity in the imaging studies. I want to make a really important point about the diversity of the patients. So this is like many neurological diseases in children, a very diverse disorder, but even more so with HH. So virtually every patient that I meet will have something about them that I have not encountered with a previous patient. So it is true that each of your children are unique in their own way. There are certainly some common themes that we see over and over again. There's no doubt about that. But it is also true that each of your kids are unique. And so when you're sharing with each other, just keep in mind that your child won't be exactly like the child of the parent that you're speaking with. So to develop the clinical features just a little bit, usually I'm referring to gelastic seizures here as Act 1. Typically, the gelastic seizures begin very early in life. We definitely have families, typically it's the mother, who can say that they were occurring in the delivery room. And there are some moms that I think give a pretty compelling story for the gelastic seizures occurring prior to delivery, based upon kind of recognizing a pattern that they can determine. They are usually very brief. They're very frequent. So this is not, one a week kind of an experience. This is often many per day, if not several per hour kind of an experience. They can be very subtle. And we know from older patients who can tell us about their experience that sometimes a gelastic seizure can just be a feeling that you need to laugh without anything really being apparent, even externally. So they can be extraordinarily subtle. I know that families in this room will connect with this, but usually it's not the appearance of true laughter. So for most parents, you kind of name that tune within the first 3 notes. For most parents, even from the other room, your ear will tell you almost immediately whether it was real laughter because something was funny, or whether it was a gelastic seizure event. And of course, some of the kids look a little bit more like they're crying or distressed rather than laughing. They're notoriously refractory to medications. One of the things that we learned, this is one of the early discoveries, is that the HH lesion itself is intrinsically epileptogenic. And what that means is that the gelastic seizures originate from the HH. And that was a counterintuitive idea. It used to be thought that subcortical structures were not capable of giving rise to seizures, and that the HH was a marker for problems elsewhere in the brain. But it turns out that the HH lesion itself is actually where those seizures come from. And this is what that looks like here. So this is a patient who has electrodes inside the head. These are surface electrodes over the lateral surface of the brain. Here's a depth wire into the HH itself with the red arrow. And these are all the various recording electrodes. These particular contacts are the ones that are in the HH. And I think you can even see from the back of the room that there's a spike pattern here that emerges in those particular contacts when this particular patient had a gelastic seizure. Okay, so that's a single example of a very compelling story that gelastic seizures do indeed come from the HH. But unfortunately, it's usually not the case that patients continue to have just gelastic seizures. So there is an Act 2 to the whole story, which is that other seizure types do emerge. And these are often the seizures that are much, much more problematic for family life. And sometimes, for some patients, this is when the diagnosis gets made. They may have been having gelastic seizures that were never recognized, called reflux or colic or any number of things. But when other seizures come up, then basically a scan gets done. Virtually every different type of seizure that we have in the field of epilepsy can be associated with patients that have HH. Okay? So focal seizures, seizures that look like temporal lobe epilepsy, generalized seizures that would mimic some of our more disabling epilepsy syndromes like Lennox-Gastaut or infantile spasms. These are all possible. And typically that transition occurs somewhere in the neighborhood of 4 to 7 years of age, basically preschool, very early school age, although again, there's always exceptions and unique experiences. These seizures also tend to be very refractory to medications. I don't want to say that they're not at all responsive. I think that there is a role for medication management in terms of trying to control these more, troubling, more disabling seizures. But typically they don't respond entirely. We don't end up with a fully controlled patient like we do with other forms of epilepsy. Dr. Burrell is going to be giving an entire presentation on this particular subject later. I just have a single slide here to kind of set the table for her. Cognitive issues are an important part of the story. At least 80% of patients will have some degree of difficulty. For some, that may be a very mild learning issue, and they can compensate for it, very easily. Other patients can be very disabled with intellectual disability, and a small number of patients may be nonverbal. So it is a problem. And unfortunately for many of those patients, roughly half of the patients that have HH with epilepsy, there can actually be a deteriorating course that can occur with cognition, so that there's an actual decline or loss of things that they used to be able to do. And that typically occurs at the time when seizures worsen. So when you make the transition from gelastic seizures to the other seizure types, typically that's when these other issues begin to become clear. And we've identified some risk factors. These are statistically significant, kind of, shall we say, proven risk factors. It's not just one thing, but it's a host of things, which can include earlier onset of seizures, more frequent seizures, a larger HH lesion, there is an impact of the medications that we use. It's a pretty consistent theme that the more anti-seizure medication that you're on, that your scores actually can drop a little bit. So it is something that does impact. Psychiatric symptoms go hand in hand. That's the neurobehavioral comorbidity of having HH with epilepsy. Dr. Salpeter later today is going to give an entirely separate talk on this topic as well. But 83%, 4 out of 5 patients have psychiatric symptomatology of one kind or another. Again, there's a lot of diversity. Virtually error-free psychiatric diagnosis from the diagnostic manual that the psychiatrists use can be seen, mood disorders, anxiety, what have you. However, the hallmark issue is a problem with self-control, with frustration tolerance, and with acting out when provoked in a very minor or even trivial kind of a way with what would be sometimes called a rage attack. Not all kids have this. Not all patients have this, of course. But for some, it can be the most disabling component of their condition. A paper this year actually has come out that now has identified, proven, if you will, some risk factors for the psychiatric comorbidity. There's a lot of overlap here that you'll see with the cognitive risk factors. It includes male gender, that there is a biological reality to gender differences. Earlier age for the first onset of seizure, the presence of intellectual disability correlates in favor of having more trouble with rage behaviors, and multiple seizure types rather than gelastic seizures only. So the model that we end up with is this. We think that most patients, the vast majority of patients, not 100%, but the vast majority of patients, when they're born, have an HH with an otherwise normal brain, okay? And you start off life with gelastic seizures. However, it can be a progressive condition for many patients and many families where we end up with a mixed seizure profile with other seizure types, often more disabling, cognitive issues, and then the behavioral issues. And then again, recall that 40% of patients that would fit on this slide would also have central precocious puberty, which usually can be treated medically, by the way. So usually that's not something that requires surgery. Okay, so in terms of the research landscape, I like to show this slide, which basically does a search on PubMed, which is the U.S. government-funded website. It's available to anybody. You can just, in the search engine bar, put in PubMed. It'll come up. There's another search bar where you can put in whatever it is that you want to look at. If you put in hypothalamic hamartoma and epilepsy, I did this just a few days ago, there are now listed 391 papers. And if we take that entire list of papers and break them down by 5-year intervals, this is what's happened over the last 2 or 3 decades, or 4 decades, I guess, in terms of research publication. So you can readily see that up until the 1990s, there was very little, if any, kind of clinical research going into HH. Really quite a rate of rise here into the 2000s. The blue bar here is the first 2 years of our current 5-year interval. If I extrapolate out to 5 years, out to the year 2020, basically this is what it might look like when I give this talk a few years from now. So it is still showing an incline, which is to say that we're getting more research over time. I don't think that we'll necessarily sustain this rate of rise, and we might see a little bit more of a plateau effect, but it is good news that we are still learning about this condition, which of course is so very important. Basically some of the questions that are important, how common is it? From Scandinavia, we have good data where basically they capture their entire population in a pretty rigorous way. That 1 out of 200,000 children and teenagers have HH with epilepsy. So this is not the cohort with precocious puberty only. That would give us, based upon 2017 estimates, about 10,000 patients around the world that have HH. For the U.S., 300 patients. For China, 1,100 patients. For India, which has a much younger demographic compared to both China and the U.S., up around 1,800 patients or so. So not an everyday condition for pediatricians, certainly. Not an everyday condition for pediatric neurologists or even pediatric epilepsy specialists. And this really brings out the idea that you'd like to have centers that really begin to develop some multidisciplinary expertise in terms of taking care of patients with complicated conditions. So why are there 2 different syndromes? We talked before about the inside the ventricle and below the ventricle story. It turns out over just the last few years, we've done a little bit better than that, which is that it does relate to the anatomy, but from a different perspective. So here we have a sagittal MRI sequence. The nose is up here. The back of the head is back here. The top of the head is up here. This is the brainstem. This dark space is the third ventricle. And here's an HH lesion here, which is associated only with precocious puberty. It's very close up to and basically adhering to, it's intimate with the stalk of the pituitary gland, which is here. Here's a patient that has HH with epilepsy. Here's the same anatomy, brainstem, third ventricle here. I realize that this is a subtle difference if you don't look at them a lot, but a very important one. Here's an HH lesion here within the third ventricle, but located much more posteriorly within the third ventricle. And we now know that the location of that lesion would correlate very, very highly with the presence of epilepsy. So we can kind of look at the scan and do a pretty good job of predicting whether the patient would have precocious puberty or epilepsy. And then, of course, we've got patients with very large lesions. This is the HH lesion here, which attaches both anteriorly and posteriorly, and therefore is associated with both precocious puberty and with epilepsy. What causes HH? There's a condition, 3%, 5% of patients with HH have a condition called Pallister-Hall syndrome that involves other malformations of the body in various locations. And it was known that patients with Pallister-Hall had a mutation in the GLI3 gene, or the GLI3 gene. And so that was a little bit of a clue for us to look for what we would call a somatic mutation in HH, which is to say there's not a total body mutation like there is in patients with Pallister-Hall, but rather a somatic mutation, a mutation in the tumor only, and the rest of the body is normal. And a few years ago, we looked at that possibility and found that GLI3 indeed was abnormal. There was a mutation in that particular gene in some patients with HH. And within the last year, we took that even further to use some more advanced genotyping type techniques to ask the question, could it be affecting other genes? And indeed, that turns out to be true. So basically, GLI3 is part of an intracellular signaling pathway called sonic hedgehog, and other genes, which the mutations in the gene, of course, resulting in an abnormal protein, other genes within that pathway are also affected. So we now know that up to 40% of patients with HH can have a mutation within this pathway. This is a little cartoon here. This is the extracellular space. This is the cell here with the nucleus. And basically, this is what we would call an intracellular signaling cascade, where a protein binds to a cell receptor, and that initiates a cascade of changes that eventually end up in the nucleus and affect how genes are expressed. Okay? So basically, this is a condition that alters how the cell expresses or shuts down the genes that it's making, and a lot of times those genes control things like growth and what have you. Another question would be, why do seizures arise from HH tissue, which for people in my field is a very interesting question. Each form of epilepsy has a unique story in terms of the exact molecular and cellular reasons why that particular seizure, or that particular tissue would have the tendency to cause seizures. It turns out that HH tissue, when we look at it in a patient who has had surgery, and of course we have permission from the family to do that, it turns out that HH tissue is really relatively simple. With with clusters of neurons. This is a cluster here. They're kind of irregular, not highly circumscribed. Neurons are these cells here. That's the nucleus of the cell, kind of a lacy material within the nucleus with a dense nucleolus, which is that little tiny dot, whereas glial cells, which are the supporting cells, have these very dark nuclei here. Okay, so this is basically a field with a cluster of neurons. If we take the opportunity to try to drill down on that a little bit, we discover that there are, at least so far with our relatively simple model, two different cell types. We're still calling this the large HH neuron and the small HH neuron. I have no doubt that we'll come up with better names in the future, but that's what we're still using as of today. About 90% of the cells are these very simple cells, and about 10 of the neurons are those very simple neurons, and about 10% of the neurons are these more complicated cells. And don't worry about the details here, but we can study the behavior of those cells in living, just recently resected tissue if we try to maintain it with artificial oxygenation and giving it glucose and what have you. So the tissue slices can have intact cell activity for 12 hours or sometimes even 24 hours. So with microelectrode recordings, we can study the behavior of those cells. Let's not worry about the details on that. This is a picture of a couple of large HH neurons here. This is a recording of a small neuron and a recording of a large neuron. And I think you can see, without kind of even knowing what it's all about, that these two cells are behaving differently. This cell is firing actively, then quiet, then firing actively in response to this particular chemical. This cell is quiet, then firing, then quiet. So large cells and small cells do behave differently. And that leads us to this, which is our goal. This is what we want. This is a model of the cellular network within HH tissue. So this box is meant to be the inside of the HH. And we begin to get a sense of, how are those cells behaving, what's in there, what are they doing, and that gives us an opportunity to then do hypothesis-driven research, which is to say we've got a very specific question and we can test, is that true or isn't it? We can do a neuropharmacology in the tissue slice, so basically the tissue slice is in the lab, and we can, shall we say, kind of spritz a medication on while we're watching how the cells are behaving, and then wash that chemical away and see the cells return to their prior activity. And we've done, it's still early in the story, but we've done a fair amount of work with this kind of stuff, and these are the various compounds that have been shown to have some impact on the way that HH neurons behave in tissue slice. I should point out that the CBD story is a very preliminary observation, but the others are worked out to a greater degree and published, whereas the CBD is not yet a published observation. But this slide makes the point that we really have not had the opportunity to look at any of those in a properly conducted study in patients. So this is work that's kind of undone. Doctors like to talk about translational research, things that you learn about in the laboratory that then allow you to treat your patient or to investigate that treatment in patients. That sometimes gets said as a bench to bedside experience. But this is work that really is out there to be done. And there are reasons that it's a challenge, one of them, of course, being HH is a rare condition. Funding is often another challenge. But the laboratory work does give us some thinking about what we might want to look at in actual patients. Dr. Boerwinkle is going to be giving a presentation later today on exactly this topic, so I'm going to allow her to tell you about her technique. But basically, this is one of the efforts to get a look at what's happening in the rest of the brain. So all the things I've shown you up till this slide were based upon looking at surgically resected tissue. But the very important questions, like why is there a cognitive issue, why is it getting worse, why are there psychiatric disturbances, are whole brain questions. And of course we need to use techniques like imaging techniques in live patients to be able to do that. So Dr. Boerwinkle is going to tell you a little bit more about that today. We are beginning to get a sense of what networks or what circuits in the brain the HH plugs into and likely impacts. And she'll be addressing that. So I'm going to close with a few slides on treatment. Back in the year 2000, we literally did not have any surgical therapies for this, or we did not have any that were encouraged. Now it's 2017. It's been a very rapidly moving landscape, and for me, a very exciting one. For parents and for patients, I'm sure a very confusing one, where we now have, maybe we have too many therapies. Pterional or orbitozygomatic means coming under the bottom. That's the way that the surgery was done traditionally. I'll show you results with that momentarily. Transcallosal, coming from the top between the two halves of the brain. Endoscopic, putting an endoscope through a burr hole, going into the lateral ventricle with the scope, and then into the third ventricle with the scope, and then excising the lesion in that regard. Gamma knife radiosurgery, an entirely non-invasive technique where a helmet is applied to the patient's head and beams of radiation converge on the target in a way that it damages the target, not the rest of the brain. Interstitial brachytherapy is really done just by one center in the world, which is in Freiburg in Germany. But that's a technique of putting radioactive seeds temporarily into the lesion and then removing them after a week or so. And then the most recent approach that I'm going to spend time with is stereotactic thermoablation, in which a probe is put into the lesion and then heated. And that can be done either with electrical current or with a laser way of delivering energy. This is a very large HH lesion here. I'm going to tell you about what I'm going to now call three phases of treatment that we have now kind of gone through. This is the phase one, or the phase prior to the year 2000, when the transcallosal procedure came on board. And kind of a complicated slide, but I want your eye to come to this line here, which is what's the efficacy or the effectiveness of the treatment. And I'm going to focus on 100% seizure-free as the outcome that we want to achieve. Okay? Certainly patients who are 90% better are helped, no doubt about it. But what we would really like, of course, is to hit the home run and get 100% seizure freedom. Okay, so that's the number I'm going to focus in on for this purpose. So this was an era here where all patients were treated with coming from below to get at the lesion. And we've already said that a lot of patients with epilepsy, most of the patients that have epilepsy, have their lesions within the third ventricle. That's a very hard place for the surgeon to get from coming from below. So the success rate was very poor. 15% of patients, 1 or 2 out of 10 were controlled in that regard. We then entered what I'm going to call phase two, and this doesn't seem that long ago, but it is. Now we're going back to when we first started our program back in 2003, and these are the various techniques. These are kind of single important papers for each of these techniques. Here's the transcallosal approach, endoscopic, gamma knife, and then the radioactive seed approach here. And again, just let your eye kind of travel across here. So, anywhere between 37 to 54%. These are not identical patients. These are different patients being treated with different techniques, patients with different kind of lesions with different techniques. They're all HH lesions. They're just, some are big and some are small, and the patients are not perfectly identical. But you can see here that we made a pretty significant jump in terms of effectiveness. In round numbers, let's say we got up into the 40% cure kind of a rate. The latest player, of course, is the thermoablation story. This is where a probe is put into the HH lesion, and then with a near real-time MRI technique, MRI thermography, the MRI unit can actually see thermal signal. So the surgeon can watch as the thermal signal is spreading or increasing, and then basically turn off the device when it appears that the lesion's been treated, or if it appears that the heat is beginning to get close to structures that you need to stay away from, okay? So there's some control. It's not a blind technique, but rather a controlled technique. And this is a relatively recent development, and the peer-reviewed published research papers on it are still, I'm going to say, rather modest. This was the initial report out of Baylor in 2013, which was a very early paper treating 14 patients. Only 4 of the patients were a year out from surgery at that time. These are subsequent papers, including ours, which is currently in press. Here's the 100% seizure freedom rate. There's some spread here. What I think is true is that this number is a little bit lower because more of our cohort was at least a year out from surgery. The results that you have a month after surgery may not be the results that you have a year after surgery. It may also be that the cohorts were not identical cohorts. But let's use round numbers again. Let's use a round figure of 70%. So we've gone from roughly 10% success to roughly 40% success, and now with what I'm calling phase 3, roughly 70% success. And I know for families, the only patient that really matters is your child, but what I can tell you, though, is that that's actually tremendously rapid progress for a condition of this sort, okay, that 20 years ago was often regarded as not treatable. And there are still people in the world today who are being told that nothing can be done. So what emerges from that whole business is that any one of those techniques is not ideal for every single HH patient. So we need to begin to have some kind of a landscape for which of all of those many treatment approaches should be applied to individual patients. And a large part of that has to do with the anatomy. This is one classification scheme. This happens to be the one that I like. Excuse me. Relatively simple and straightforward, but the various anatomical types that you can see here on the screen. And then that can lead to a treatment algorithm. Don't worry about the details here, but here's type 1, type 2, type 3, type 4, going back to the types that we see here, so that we can actually come up with a treatment algorithm that says of our universe of various therapies, these are the ones that you should consider for that particular patient, okay? So another way of saying that is that treatment really does need to be individualized. The ideal circumstance is that you're linked up with a multidisciplinary center that has most or maybe all of those techniques available, so that the treatment is being chosen based upon the characteristics of the patient. What's the anatomy? What's their natural history? Are things stable? Are things going downhill quickly? That then would lead to choosing the therapy for the patient rather than, that's the one thing that we do here, kind of an approach. So just the last couple slides here. This is the latest player in the game. This would truly be in the realm of something that's currently investigational, but there's some excitement about it, and so I think it's very much worthwhile mentioning so people can keep an eye on how this story develops. So this is a transcranial MRI-guided focused ultrasound, a similar idea to gamma knife radiosurgery. So there are a number of transducers or energy-producing modules that are, a large number of them arrayed around the head, which are all pointing in such a way that their energy is converging on a single target or at a single point, okay? This is not radiation such as would be used with gamma knife, but rather ultrasound energy, okay? So this is an entirely non-invasive technique. This is not an HH patient. This is a slide that was made available to me from Dr. Fountain at the University of Virginia, but this is a patient with a movement disorder where they were trying to put a lesion in the thalamus to help the patient alleviate a movement disorder that wasn't responding to therapy. My point here is how small the lesion is. This is post-op day 1, 1 week post-op, 1 month post-op, and then 3 months post-op. And so I think you can get a sense of how focused that energy administration can be. So this turns out to be in a very exquisite way of putting a lesion, destructive energy, into a very small space, which of course you have designed with the use of the computer and the use of the imaging. And Dr. Travis Tierney from Miami Children's Hospital is here in the room today. I don't have his slide to put up on the screen today, but I do have one from Dr. Fountain. So there are currently 2 centers in the country, if I understand it correctly, 2 centers in the country that have permission to go forward with investigational treatment for this technique for HH patients. And one is Dr. Fountain, who I think is going to be specializing pretty much, I think, in adult patients, and then Dr. Tierney at Miami Children's Hospital, focusing on the younger population. And these, maybe we'll hear a little bit more about what they're actually experiencing so far. I think there have been a couple of HH patients treated thus far.
That's right. Currently, the way the FDA structured our trial was that it's a safety trial. As you said, this is experimental. So they wanted adult-like patients done first. And our initial window was between 18 and 22. And we've completed those two patients. And our trial is now open down to age 12.
Mm.
And we just treated our second patient a couple of weeks ago.
Mm.
Our first patient was treated 6 months ago. It was a hamartoma remnant. And as you mentioned, the beam is very tight, so it's ideally placed within the brain for this particular type of therapy. We have 8 more patients to do.
Yeah, so definitely something to pay attention to in terms of the patient community. So I want to close by acknowledging the patients that we have treated. Our program started in February of 2003. Our next patient will be next week, but this is where our patients have come from throughout the U.S. and from elsewhere around the world. A pitch for Hope for Hypothalamic Hamartoma. If you're in this room, you're knowledgeable about it, of course, but this is really your organization, and I think that HHH is approaching it in the right way in terms of putting out information to families, which is legit and validated. Thank you very much, and we can take some time for questions. Okay. Who has a question? Yes.
The mutation that you spoke about, the mutation of the pathway,
Uh-huh.
is that something that is ongoing, or is that something that took place at conception and happened at one time and led to the initial development?
Right. So the thinking there is that the mutation occurred, and that's why the HH is there. The mutation caused the lesion. So it's not an ongoing phenomenon. It was an accident of development in just that spot in one of those genes involving that pathway. And because of that, those cells get dysregulated and grow. As everybody knows, HH is not a cancer. It is a mass, so it can be called a tumor. It is a mass. Sometimes they're very big, as you saw, but it's not a cancer. But anyway, but cells were dysregulated and, at least for a time, growing out of control in a disordered way. Okay, and that results from the mutation. Sure. Yeah. Yes.
So after first surgery, for example, laser ablation, the patient may still have greatly reduced the number of seizures, but he may still have 3 or 4 times per day. So in that situation, do we do it more proactively? Like when should we repeat RMI scan to see if we need another surgery, or we just let it go? But will this be the case that can evolve to some more complex seizures? The first surgery is pretty successful, greatly reduce the number of seizures, but then what should be the next step? What should we?
Yeah. Well, excellent question, and I know you're asking about your child. So it is really individualized, that kind of response, and I don't know your child. So in terms of when should a follow-up scan be done, there should be a post-op scan done. Right immediately after surgery. I mean, a lot of times the surgeons will do one right after surgery because they want to make sure that there wasn't a complication, right? They want to make sure there wasn't a stroke or bleeding or something unexpected, right? So a scan often does get done right after. But you want to let things calm down a little bit, and whether that's 2 months or 4 months or 6 months, doctors will have different opinions about that. But there should be one, I'm going to say a few months downstream, to then look, okay, things have calmed down, the swelling, from the acute trauma of surgery has gone away, what's left? Okay, so and that would be you would be more likely to do that sooner in a child that's continuing to have seizures, of course. If the seizures just disappear, then you can kind of do it when you want to. I'm not a surgeon, but I think I can speak for the surgeons on this particular point. They will generally do a more conservative operation rather than a more radical operation, because there's a very, very high premium on not removing normal hypothalamus, okay? So they'll tend to under-remove rather than over-remove. So the experience of having some residual is not an uncommon one. And a second operation can be done. But the whole process needs to be rethought again. So you don't go back and just do the one you did the first time. You may indeed pick an entirely different treatment approach for the second one, if a second one's required. Yeah. Yes?
You talked about the statistics for genetics.
Uh-huh.
I'd like to know if you have treated, in your experience, kids with OFD1, or fast digital 1-5 syndrome, with hamartoma.
Yes, small numbers. So I mentioned Pallister Hall. Sorry, okay. Yes, okay, sorry. So the gentleman has asked that there is a particular syndrome, OFD, oral facial digital syndrome, which can also be associated with hypothalamic hamartoma, and have we treated patients with that? And the answer is yes. I mentioned Pallister Hall as a syndrome in which HH occurs. There are others, and the OFD collection is another one of those syndromes, but even less common. So in our experience, I think it's been a couple of patients. Yeah. At least so far, I'll speak to my own experience. We have not discovered that the presence of the syndrome or not having a syndrome in any way influences our treatment decisions. It's the same treatment algorithm. It's not different if you have Pallister Hall versus OFD versus the most common, which would be just a sporadic HH.
Thank you very much.
Sure, yeah, yes.
Have you seen anything in your research with Pallister Hall, the genetic ability to pass it on to their children?
Have I seen, with the genetics of Pallister Hall, is it possible that they can pass it on to their children? The answer is yes. Well, the short answer is yes, that is possible. So that can happen. But I'd want you to, it's actually a pretty complicated story, the whole Pallister Hall mutation story. So I would definitely want you to get an expert opinion on that to really talk a little bit more about your individual family and what have you. Sure. Actually, the NIH here, since you're in town, I can't get you an appointment, but the NIH here is one of the genetic leaders for Pallister Hall specifically. Yeah. Yes, sir.
The slide where it had the figures, 2 slides, where they're quote unquote cured and 100% seizure free
Mhm.
after 1 year. What percentage of those people are permanently cured in terms of the data that you have following up in subsequent years?
Yes. You're asking a superb question. The answer is in that case right over there, because we're currently working on that paper. You're asking a very good question, which is that I personally don't like the word cure for exactly that reason. So the success rate with 100% seizure control is lower at 1 year than it is at 1 month or 3 months. And it's lower at 5 years than it is at 1 year. We know that that's true for all forms of epilepsy surgery. There's nothing unique about that with HH. So if you have temporal lobe epilepsy, the most common epilepsy surgery, of course, is temporal lobe removal. That's also true. And it's something that doctors have been, kind of slow to realize, but because it's harder to do long-term follow-up studies. You have to track people, and people move and all that kind of stuff. So there are harder studies to do. But it is true that there is a phenomenon of, falling off the wagon, at a later time point. That does happen. We're deep into the analysis phase for that exact paper. And I think what I can tell you right now is that it is also true for HH, but not to a severe degree that I was thinking might have been the case. Because I certainly hear from a lot of families that have gone 3 years or 5 years or even 10 years, and then their child had a seizure. And what I had in my head is that the rate was pretty high. But of course, I'm hearing from the families where their child had a seizure. And the families that don't particularly have a need to call, because people live all around the country, of course. So anyway, it does happen, but it does not appear to be to any greater degree, and maybe even a little bit of a lesser degree, compared to other forms of epilepsy surgery. So was that a good answer? Okay, yeah. So, and I'm hoping that we'll be submitting that paper within the next few months to look at the treatment outcome in patients who are at least 5 years out from surgery. And that's our cohort that you saw on that slide with the red dots.
One last question.
Yo-yo.
The general impact of the seizures, what we have today with those different EEGs and stuff like that,
Mhm.
don't necessarily always manifest exactly how much impact the gymnastic seizures actually have on the cognitive behavior of the child.
Mhm.
One of the dilemmas that most parents have is whether it's post-surgery, pre-surgery, they have several seizures a day, is how much actual impact it has on the child's cognitive change.
Mhm.
And sometimes we go into surgery thinking that that's the right thing to do because hopefully we'll stop the seizures, but as you said, there's a premium to that any kind of surgery. What other measurements do we have to measure how much impact these seizures actually have on the child?
Okay, so the question is, what is the biological impact of having gelastic seizures preoperatively and perhaps postoperatively, and how do we weigh the decision-making process of when is surgery called for versus the risks of surgery? Okay, you're asking a really good question for which I don't have a good answer, right? So we don't have a good, validated, reliable, consistent biomarker for that process. We just don't. EEG is one of those things. The neuropsychological testing profile is one of those things. Maybe that's the most important. How is the patient doing with their seizures and their behavior? Those are all things that go into the mix. But it is a challenging decision-making process. I think we have a pretty good sense of the natural history. Excuse me. I think we have a pretty good sense of the natural history prior to surgical treatment. In other words, if nothing is done, what happens? And those were some of those slides I showed you that there's, 80% will have trouble and 50% can show some downhill decline. More likely to occur with bigger lesions, early onset. The earlier the trouble, the worse it's going to be. What we don't have good evidence worked out on post-op improvement, but still having a few gelastic seizures. And that's a common scenario for many of the families in this room, okay? What I believe to be true is that we have altered the natural history so that there's a more favorable natural history if you've gone from having 30 a day to having 3 a day. And again, when I make that comment, it's kind of assuming that the gelastic seizure is the thing that's causing the trouble. And that's not worked out, right? It may be the presence of the lesion. And if you've reduced the mass of the lesion by 90%, that you've impacted the natural history in terms of how things go. Because the biology of what's happening to cause that decline isn't known. And I'm looking forward to Verina's talk later, but it's her tool and tools like hers, perhaps done with patients over time, to really help us get a handle on where in the brain is this stuff happening, and then hopefully why. And if we can understand those things, of course, then maybe we can impact them. So you're asking an excellent question, and it gets kind of to the heart of the matter in patients who have had treatment. But we're still kind of finding our way with that one.